Okay, so first of all, thank you so much for inviting me to discuss my favorite topic, which is lifestyle and muscle, because lifestyle is actually the main treatment of muscle. It's the cornerstone of muscle treatment. And what I will do in the next about 20 minutes is to share with you my experience, the most recent literature, but also some very practical advice for the busy clinician. Um, so let's start with what are the foundations of lifestyle treatment of muscle. So we can say there are three main components of treatment. One is weight reduction, which is the most evidence-based treatment for muscle, and it goes with the dose-response association. The more you reduce weight, the more you improve muscle features. 5% is sufficient for most patients to reduce steatosis significantly. For MASH resolution, it takes usually more like 7 to 10% weight reduction. And for fibrosis regression by at least one stage, most patients would need 10% weight reduction and above. But it's not all about weight reduction, and the dietary quality, the dietary composition is also very important, as I will show you in many slides later on. And also, of course, physical activity has independent effect on muscle, on all features of muscle, mostly on steatosis, and should be a component of any lifestyle modification. And you can see in the base of this slide, multidisciplinary team is needed, and it should be led by the primary care physician, the one who coordinates the entire treatment, including the lifestyle treatment, and creates the motivation in the patient to change his lifestyle, is the primary care physician. Now, when we talk about treatment of muscle, we also need to discuss prevention. We can treat muscle with that, but we can also prevent muscle and its complications with a healthy lifestyle. And therefore, the new 2024 EASL, European Association for the Study of the Liver guidelines, emphasize prevention. And they state that in the general population, lifestyle should be recommended to prevent the development of muscle and its complications, including liver cancer. So every time we treat those patients for MASLD, or we think about prevention of MASLD, think about also prevention of liver cancer. What are the lifestyle components that we are going to discuss? So I mentioned weight reduction, of course, and diet, but also keep in mind that smoking is associated with MASLD and with more advanced fibrosis and with liver cancer. And in the discussion on the quality of diet, we are going to discuss sugar-sweetened beverages, which are related to MASLD. This has been repeatedly demonstrated. High fructose diet, red and processed meat are also strongly associated with MASLD. So we will keep discussing these topics in the next slides. When we look at the guidelines, the most recent guidelines, international guidelines, the ASLD guidelines, the EASL, ISAD, ISO guidelines, it's the Liver, Obesity, Diabetes European Associations, and the ESPEN guidelines, we can see how coherent it is in the recommendations for MASLD. There is a great agreement actually in the guidelines. So weight reduction, as I mentioned, they all agree about it. Dietary pattern, it is very much agreed that the Mediterranean diet is the best diet, or something similar to Mediterranean diet, with a special emphasis on restriction of added sugar in the diet, added fructose, and reduction of saturated fat, which I will show you some more evidence later. Of course, physical activity is recommended, and most guidelines recommend around 150 minutes of moderate physical activity per week, or 75 minutes per week of more vigorous intensity physical activity. Some also recommend the addition of resistance training once or twice a week at least to keep the muscle mass. And some of the guidelines mention coffee as beneficial. Coffee has been demonstrated repeatedly in the prevention, but only in observational studies, in the prevention of liver cancer and lower stages of fibrosis, but this needs further confirmation from randomized clinical trials. So let's talk a little bit about how we get weight reduction. There are many options to get a weight reduction. There are many types of diet, right? And one of the latest diets that many patients ask about it and actually also do them is the intermittent fasting diet or time-restricted eating diets. So just keep in mind that there are several types, in fact, of intermittent fasting. There is the alternate day fasting. One day you eat very little, and then the other day you eat as much as you want, only healthy foods. So it's called the fast and the feast day. So 2 days a week you eat very little, and the rest you eat more freely. There is the 5-2 diet, and there is the most common one is the time restricted eating, in which you eat about in an eating window of about 6 to 8 hours per day, and then you stop eating completely. You can only drink, and this is very common among the patients, and from my experience it works very, very nicely. You eat from 8 to 4, let's say, in the afternoon, and then you stop eating until the next day. So what is the evidence on these types of diet? This is a meta-analysis done on these types of studies. And they show reduction in liver steatosis and reduction in liver stiffness following these diets. However, we need to remember that they included any study with intermittent fasting. It doesn't have to be a randomized clinical trial or even control trial. And most studies are actually short-term, a couple of weeks, and have a small sample size. So this is a limitation we should keep in mind, although the results seem very, very positive. There is one study, it was a long-term study, 88 patients, 12 months diet, time-restricted eating between 8 a.m. and 4 p.m. as compared to regular low-calorie diet. Both diets were low-calorie. And you can see that within a year, the reduction in liver fat was similar in the two diets, the usual meal low-calorie diet and the time-restricted eating low-calorie diet. And liver stiffness reduction was similar as well. So it doesn't mean that time-restricted eating is not good. It just means that it is as good as a regular low-calorie diet. And it's another tool in the toolbox that we can use with patients who feel comfortable with that. If I need to summarize the diets that are mostly available or used these days, so I would put Mediterranean diet, ketogenic diet, and intermittent fasting that I mentioned. Now, the ketogenic diet, I am asked a lot about patients and physicians about the ketogenic diet, and we need to remember that the evidence is very weak with regard to MASLD. Most studies are short-term. It's a very difficult diet to keep. It's very low-carb diet, and it's very difficult to keep in the long term. And it might have also side effects. For example, some patients eat a lot of saturated fat, and we don't know in the long term if it's not harmful for the liver and also in terms of cardiovascular health. So I wouldn't recommend ketogenic diet with a lot of saturated fat. The problem with the Mediterranean diet is just one: it is expensive. Not everyone can afford eat fish 3 times a week, olive oil, walnuts, a lot of fruits, a lot of vegetables, fresh fruits, fresh foods in general. It's more expensive than processed foods, and so that could be a barrier for the Mediterranean diet. And the intermittent fasting, as I mentioned, the evidence is reasonable, but we are not convinced it's better than a regular diet. Definitely patients with cirrhosis should not have this type of diet, because many hours of fasting per day are not recommended to patients with advanced liver disease. So just keep it in mind. So if I need to summarize, you can see the conceptual summary of the diet. You can see that there are many diets: low carb, low fat, ketogenic, and so on. They all can be tailored to the patient's preferences and clinical history. But you can also combine the diets. For example, if a patient wants time-restricted eating, you can have Mediterranean diet with a time-restricted eating, or low-carb or low-fat diet with time-restricted eating, or low-carb diet combined with Mediterranean diet. All I'm saying is that we can tailor the diet to the patient, to the needs of the patient, as long as the diet doesn't contain red and processed meat, saturated fat, and sugar beverages. Let's talk a little bit about the diet quality. We talk a lot these days about ultra-processed foods. You can see examples in the pictures here about how ultra-processed food looks like. It is highly industrialized food, and unbelievably, about 40-50% of the calories in many countries of children and adults come from ultra-processed food. So what is the problem with it? It is very rich with sugar, saturated fat, and unhealthy ingredients that are harmful for the liver. And how do we recognize ultra-processed food? We look at the list of the ingredients, and usually it contains a long list, more than 5 ingredients, and you look at it and you don't recognize the things there. It's not things that you use in your own kitchen, then you know it's ultra-processed food. And also usually it comes with plastic packing and cans. Everything that is ready to eat or heat is probably ultra-processed food. And here is a nice prospective study showing a clear dose-response association between the amount of ultra-processed food in the diet and the risk of having MASLD. So there's a clear dose-response association. There's also this study from the United States, from the Enhance survey, which I like very much because it showed the independent association of ultra-processed food with MASLD. So what you see here is that when you adjust to demographics, education, smoking, BMI, there is 83% increased risk of having MASLD. But even when you adjust to the healthy eating index, or to added sugar in the diet, or to saturated fat, or to refined grains, the association remains, and it remains strong. So there is an independent association between ultra-processed food and MASLD, even independently of certain ingredients in the diet. And this is just to give you one example of many of the association between sugar beverages consumption and MASLD. So you can see a dose-response association. If you drink more than 4 servings of sugar beverages per week, you have 45% increased risk of having MASLD. There is a clear also in the figure below, a dose-response association. The more you drink, the more you increase the risk. What about saturated fat? Saturated fat has been repeatedly demonstrated in randomized clinical trials, in short-term trials, where there was overfeeding with either saturated fat or unsaturated fat. You can see in the dark green that saturated fat repeatedly increased the amount of liver fat, whereas unsaturated fat did not increase significantly the amount of liver fat. And that goes along with the Mediterranean diet. Mediterranean diet is low in saturated fat and actually high in unsaturated fat, in olive oil, walnuts, fatty fish even, which are rich in omega-3 fatty acids and good for the liver. But always the types of diet keep the saturated fat low, and this is one of the reasons we recommend the Mediterranean diet. Now, patients at that stage usually tell me, okay, so what can I eat with all these restrictions? So you can see in green and gray the foods that patients can eat. There are many foods that the patients can eat which are either good for the liver or at least not harmful for the liver. And in orange, you can see the foods that are definitely evidence-based harmful for the liver. We recently showed in a study, in a prospective study in Israel, that consumption of low-fat dairy products is related with reduced risk of having MASLD, while high-fat dairy products, high in saturated fat, increases the risk of MASLD. So patients can definitely eat dairy products, but low-fat. And I mentioned meat a lot. So should we all become vegetarian or vegan? Well, not necessarily. I mean, it's always good to reduce the amount of meat we eat, especially red meat, and avoid processed meat, but it doesn't mean we have to be vegetarian. But if you do decide to be vegetarian, you need to do it right. So sometimes patients come to me and say, I decided to be vegetarian and I eat potatoes with corn and rice. So it's carb with carb with carb. They don't eat the right diet, although it's vegetarian. So if you don't keep a good vegetarian diet, you don't reduce the risk of MASLD. If you eat junk food, it doesn't help you. Only if you keep a healthy vegetarian diet with whole grains, fruits, vegetables, nuts, legumes, then in green you can see you reduce the risk of MASLD. It is also important to remember that these patients have a lot of times sarcopenic obesity, high fat mass but low muscle mass. So we need to be careful not to reduce their protein intake. They should have 1 to 1.2 grams of protein per ideal kilograms, per ideal body weight. So when we give them the diet, we need to keep the protein high, especially if they have evidence of sarcopenia. So dairy products, which are low fat, legumes, walnuts, fish, poultry can be good options for protein for these patients. Combining healthy lifestyle factors, giving a score to patients, not to smoke, have a healthy weight, do physical activity regularly, and have a healthy diet. If you keep those components, you have a lower risk of having MASLD. You can see a dose-response association. The more you keep a healthy lifestyle, the more you reduce the risk of having MASLD. And it's not only your regular lifestyle or what you eat in terms of macro and micronutrients, it's also the behavior by which you eat. If you eat by standing, if you eat when you're nervous, if you take another round of food without any real physiological need, if you eat while watching television, it also increases the risk of having MASLD. So it's also about the eating behavior. This is one more thing we found in this study. A few words about the lean patients, so-called lean patients, the normal weight patients. They have normal BMI, but they can have MASLD. Many times they have very unhealthy diet. They are not really lean. They have increased visceral fat as compared to controls without MASLD, and they should keep a healthy diet and physical activity just the same as those with obesity. And they can have a weight reduction of 3 to 5% of their initial body weight. They would benefit from it because it would reduce their amount of visceral fat. So keep in mind, also normal weight patients need to be treated. Physical activity I mentioned already. I just recommend to read these excellent guidelines of ACSM if you want more details about physical activity recommendations. What are the barriers of the patients for lifestyle modification? Sometimes it's lack of knowledge, and sometimes we provide them too much knowledge, and sometimes it's the fatigue that accompanies MASLD. And sometimes we tell them to do physical activity, but they don't have the availability or the time to do physical activity. And we need to tailor the treatment. We need to listen to them and tailor the treatment according to these barriers. If they know their numbers, they are motivated. This study shows that if you take patients, 6,000 or something patients were screened for fibrosis, and they follow them for 6 months, and once they knew their numbers, just like in hypertension, they improved their lifestyle. They reduced excessive drinking, and they improved their diet and got weight loss. So tell your patients their number. They need to know their numbers. As I said, every change we do in lifestyle is also related to reduction in the risk of liver cancer. So this is a summary of prospective studies and meta-analysis showing that a Mediterranean diet reduces the risk of MASLD, while high saturated fat, high red and processed meat, high sugary foods increase the risk of liver cancer. So always tell your patients they also do prevention of liver cancer if they keep a healthy lifestyle. Remember that the patients with MASLD tend to have low socioeconomic status many times or low education, and we need to be sensitive for this, and we need to tailor the treatment also to patients who have food insecurity and find the foods that they can actually afford and are still healthy. And now the next talk is going to deal with medications, but before we start with medications, we need to remember that the basis of treatment is always lifestyle modification. This is the cornerstone of treatment. And we need also to enable patients to have a healthy lifestyle. And for that, we need to have policy that promotes healthy environments, healthy opportunities for healthy nutrition, equity, and advocacy. This is also the role of physicians. We have the role to to take care of topics like equity, policy, and advocacy, and always recommend lifestyle modifications. This is a to-do list. I'm not going to go over it. I would be happy to share with you. I know I'm running out of time. Always ask permission, the patient, just ask permission. It's the first thing you need to do, to talk about lifestyle and then start talking about it. But always ask permission first. It changes the atmosphere of the treatment. And I will finalize with this slide. This is the lifestyle management algorithm of MASLD published by the EASL guidelines. I'm very proud of this figure. It summarizes everything that I said during this talk, and I hope you will find it helpful. So thank you so much for listening.